Yes, welcome everybody. Good afternoon. It is a great pleasure in name of EuroELSO to welcome everybody here to this distinctive webinar. My name is Dominik Wiedemann. I'm Professor of Cardiac Surgery and Director of the Mechanical Circulatory Support Program at the Medical University of Vienna, which is of course a center where we offer ECMO, where we offer VAD, and we also offer transplant, which brings us into the topic of this webinar, which is the transition from veno-arterial ECMO towards more advanced therapies. On the one hand, ventricular assist devices, and on the other hand, heart transplantation. But we do not only want to show you the options or the opportunities of these three techniques, but we aim more to show you different perspectives of this issue, because we have on the one hand centers which have ECMO but don't have access to VAD and don't have access to heart transplantations. On the other hand, we have centers where they have ECMO and where they have ventricular assist devices, but they don't have heart transplantations. And in the end, we have centers where all of these therapies are offered. And one of the major challenges in the field of mechanical circulatory support and in the field of transitioning these patients towards more advanced therapies, it is one of the major challenges to bring these patients from primary centers or from centers where they go in during a shock period or something else on an ECMO towards to a center where the advanced therapies are offered. And we will show you all of these three perspectives. So we have three distinctive speakers. We have Professor Roberto Lorusso, who is an absolute ECMO and ECLS expert. He is past president of the EuroELSO and is head of the extracorporeal life support program at the University of Maastricht. But Maastricht is a center where they don't have access to VAD and to heart transplantation. On the other hand, we have Mara Scandroglio, which she's head of the ICU in Milan in Italy, and she is works in a center where they offer VAD and ECMO but don't have a heart transplant program. And finally, we have Udo Boeken, who is head of the VAD program and of the transplant program at the University of Dusseldorf. So he will show us the perspective from a tertiary center. And important is also that we don't only want to show you some data, but it is very important for us also to collect opinions from your side, because we also aim to set up a document or documents for recommendations how to work together in such an inter-hospital shock team, how we like to call it, in such circumstances. Now, this is, I think, enough introduction from my side. So I'd like to give the word to the first speaker, Professor Roberto Lorusso, who I already introduced. He will give us the perspective from an ECMO-only center. What is important also, there is a Q&A, there is a question box. Please type the questions into this box. We will have a Q&A session after all three presentations, and we will try to answer all your questions and to discuss about them. So please, Roberto, give us the first presentation.
Thank you very much, Dominik. Thank you for this introduction. And well, my task is rather simple, which is to show you the two cases of patients who were submitted to a veno-arterial ECMO because of different etiologies, but the situation that we can encounter, unfortunately, during this condition, this support. So now let's see if it works. I don't see my screen as always in this case. So can you show me the slides, please? Okay, so let's start with the case number 1. Next, please. And we have the situation of a 58-year-old female with acute myocardial infarction, but arriving very late after more than 6 hours from the occurrence of acute myocardial infarction. You can see the admittance already very high CK level and also CKMB. And during the catheterization, there was unfortunately dissection of left main, and then immediately shock, actually very short cardiac arrest, shock, and then emergency bypass grafting. But we knew that due to the two things of the late admittance with a huge infarction and, of course, of the closure of the left main, the situation was really bad. So we did the bypass. We went on prophylactic ECLS plus intra-aortic balloon pump, and you can see peripheral VA. Next, please. And of course, we immediately knew from the very beginning that although the support was quite effective, the diuresis was maintained, lactates were going down. We contacted immediately our reference centers for VAD or transplant because we knew that this patient was not going to make it. And you can see that there was some sepsis arriving, antibiotics started, and then there was a question to awake the patient to understand whether there was any problem, but this was not possible because of the hemodynamic instability. So we made a request for ventricular assist device consideration. Please, next one. And then we finally transferred this patient on day 13, waiting again for infection recovery. Still diuresis maintained, so no problem for that. But unfortunately, next one, after I think the 7th day, the patient died waiting for a decision regarding VAD or transplant and for hemorrhagic stroke, really massive hemorrhagic stroke. The patient died. Next slide. So this is the second case of a 30-year-old female known for living, in a social, very difficult social situation, known from the chronic heart failure clinic for the right ventricular dysplasia with a very huge right ventricle and chronic right ventricular failure. The patient had an out-of-hospital cardiac arrest with 20 minutes of CPR. She arrived at our hospital. We put the patient on ECMO. Next slide. The patient has good hemodynamics after ECMO, but unfortunately, due to the combination of the situation of right ventricle, she went into renal failure with a CVVH required. And then we again contacted immediately the reference center. A full neurological assessment was requested. We made a CT of the brain, which was negative, and the patient awake after 7 days. She was completely in contact, so very nicely in the neurological state. Next one. And then we transferred this patient on day 9. No indication for heart transplant or VAD because of infection or still in the CVH and the social issue. And it was decided to make winning one way, so no possibility to turn back. And unfortunately, next slide, the patient died on day 10, trying to make the patient winning win from the right ventricular support from the VA, but there was no possibility and the patient died of that. So you can see two cases in which, unfortunately, we have two different situations, one acute, one on a chronic base, but again, to be discussed. I want just to show you a couple of slides about a study we did comparing transplant or VAD and transplant centers versus non-VAD and non-transplant with ECMO program. Next slide, please. And you can see that we made a review and meta-analysis. Next slide. And we saw very interesting data, including more than 13,000 patients and more than 170 studies. Next one. You can see that we had no difference in terms of neurological complication or brain death. Next one. And also regarding other kind of complication like acute renal failure or limb complication. Next slide. And again, you can see bridging to transplant, there was no difference in the two kind of center, which was quite surprising. Next slide, please. And also you can see bridging to, again, transplant or VAD was not different in the two kind of centers. Next one. But what we could see, there was a difference in terms of mortality, and it looks like there was a little bit a better survival rate in transplant or VAD and transplant center as compared to non-VAD and non-transplant center. Next slide. And we made a sort of algorithm, but this will be discussed in the panel discussion afterwards. Next slide. So I have a few questions which will be discussed by the following panelists. So next one is, when should we consider acceptable the transfer, the patient transfer? And should we, if we are not in the capacity of having a VAD or transplant center, trying to make the prolonged recovery and as an alternative and to transfer the patient? Next one. Or other way, we should deny ECMO in patients who are unlikely to recover under support if we are not sure if we can transfer the patient. Next. And again, should we instead be established a very strong, very, very connected and unified network between a non-VAD, non-transplant center to a VAD and transplant center? And finally, I think there should be a clear rules, indication, and also flowchart to be followed. But again, other points for discussion. Next slide, and the conclusive one. It's we should have something more than ECMO just to make this prolonged support more feasible, and this will be discussed by Mara Scandroglio after me. Next. Then we have also a problem of what should we, tell the family of this patient. How can we approach the family? Should we immediately explore the possibility to no bridge or bridge to nowhere to futility and stop the ECMO? Next. Another very important problem is the kind of hub and spoke, because this is very, very important. Should we make areas of this? Should we have a privileged contact? Another one very important is a non-VAD and non-transplant, a solution, with this network. And this could be important for the ECMO program. And finally, I think is, again, the shock team discussion should be always available every time, 24/7, to discuss as soon as a patient is put on ECMO in non-VAD and non-transplant center. So these are the questions that I leave to the following speakers. Thank you very much for your attention.
Roberto, thank you very much for this very interesting presentation. I think especially the cases you showed really set up the stage for later on intensive discussions, and you brought already questions for the next two speakers. So that it is a great pleasure for me to give the word to Mara Scandroglio. I hope I pronounce it correctly because my Italian is not so good. As already mentioned, she is head of the intensive care unit in Milan, and will show us the perspective of a VAD but non-transplant center on the issues of transitioning a patient from VA ECMO to a durable assist device. Please, Mara.
Thank you, Dominik, and thank you for organizing today webinar. I'm going to present a clinical case from the point of view of an ECMO and LVAD implanting center, but without heart transplantation. And I have chosen this case because it changed our process of transition from VA ECMO to next therapy. I want to present you a strategy of transition, really a pathway of care that I hope feeds such a complex topic of discussion. In 2018, we faced this case. A 44-year-old male suffered from out-of-hospital cardiac arrest. He was transferred to our unit after 90 minutes of mechanical CPR due to refractory cardiac arrest, and he was admitted asystolic and resuscitated with bedside ECPR, so really a super critical case. To complete with our protocol, an early neurological evaluation was carried out in the first 24 hours, and the patient was intact. So we proceeded to diagnostic coronary angiography and complete revascularization in the context of 3-vessel critical coronary artery disease, but chronic. And he received at that moment LV unloading. Currently in our center, the trend is moving from the concept of ECMELLA to a modern concept of ECPELLA, but at the time of this critical case, the trend had not been sent yet, and so the patient received the standard LV unloading with EABP and then with in transfemoral Impella CP, and was weaned from ECMO. Then he was stable for some days on Impella CP. He was extubated, but for technical failure of the system, he needed to be again resuscitated from severe cardiogenic shock with VA ECMO. When the pump fails, he lost the rhythm and rapidly evolved in the deep cardiogenic shock. In the meanwhile, he was evaluated for heart transplantation, but he was not listed due to prohibitive perioperative risk and low chance of survival of donor heart. And to be honest, in that moment, the clinical condition was poor despite ECMO support. As you can see in the slide, the labs were about multiple organ dysfunction with severe thrombocytopenia, and so not really a good candidate neither for heart transplantation nor for LVAD. From my point of view, it would have been just a bailout treatment, and so we choose another way of therapy. And so from ECMO plus femoral Impella CP, he was upgraded to Impella 5.0, so with minimally invasive approach through axillary artery, as you can see, and then MCS was again rapidly de-escalated. So from biventricular support, the patient was again weaned from ECMO and remained with Impella 5.0. Once again, a progressive clinical improvement was observed. At that point, the patient was extubated and he could walk around the ICU. He would eat on his own and became suitable to be listed for transplant. As a matter of fact, he was listed with the highest priority status that in Italy is national emergency. He remained 18 days on highest priority without any call from donor. So after discussion again with the Heart Transplant Center, he was implanted with LVAD and now he is doing well. And despite the development of aortic insufficiency, the patient is living now a normal life. He went back to work and is currently on, how can I say, standard heart transplantation waiting list. So what we learned and what I want to add to the discussion later, we learned to expand and rapidly consider bridging strategy. We learned that there is always a delay to get heart transplant as the treatment of choice, and I think that whatever is the final destiny of the heart, so to be transplanted or long-term supported, this kind of mid-term support permits to cancel ECMO-related complications, permit clinical improvement to maximize the result of, for the next surgery. And this policy of mid-term support, in my experience, allows constant dialogue with the Heart Transplant Center and the best chances to have, at the end, favorable outcomes. And so far, I'm presenting you with the background. Since then, other 5 patients were bridged to LVAD. after midterm support with 1 year survival of all of them. They receive ECMO, then Impella 5 or 5.0, sorry, or 5.5, and finally LVAD. And these are patients with new onset acute heart failure, rapidly evolving in cardiogenic shock due to acute MI. And these are the typical patients that can be easily supported with this kind of mechanical support. You can see the results on the screen, as LV dysfunction is the primary drive for cardiogenic shock. On the contrary, we have to acknowledge that there are patients that are not suitable for this kind of support. And more to the point, today we are well aware of the importance of the concept of bridging in terms of recovery of end organ function, in terms of being tested for heart candidacy, or in terms of testing for post-LVAD RV dysfunction if assist device implantation is indicated. Also, while we are supporting the circulation, we can pave all the possible ways of recovery. And we know that after durable LVAD implantation, recovery will happen in less than 5% of the cases. And so the moment for testing for recovery is this one, and is not negligible, because indeed in the published series of patients implanted with this big device, recovery is around 30% of treated cases. So I want to stress this point because from my point of view, it's very important. And of course, these strategies is resources demanding, and we need a lot of devices which cannot be overlooked. But I wanted to stress the real possibility to save patients' life and to bridge them in the best condition. And last couple of things, we have to recognize that the road is uphill anyway. But at the end, as I mentioned, I want to know your opinion and the opinion of the panelists about this pathway of care, and which could be the role in a spoke system dedicated to patients on temporary mechanical support. And I wanted to start to answer to the questions from Roberto, from this one. So should any center with ECMO program be part of a well-established transplant or VAD network? For me, the answer is, of course, yes. Yes, it should be a yes in capital letters. It is necessary a structure to write the relationship, not only a contact on call, because the steps of treatment should be shared. And from my point of view, I will be open in both ways. So a relationship with the center with only ECMO for patient referral, and again from patient referral from my center to a center with heart transplantation. Thank you. That's all for me now.
Thanks, Mara, for this excellent presentation. It was very interesting for me to see your vision about using midterm devices to make patients fit for finally LVAD support. I'd like just to remind the audience to type in their questions in the questions box. We will answer them later on after the last talk, but please don't forget about using this opportunity to ask questions to all different speakers. So finally, I'd like to move on to Udo Boeken, who is cardiac surgeon at the University of Dusseldorf and is heading the transplant and VAD program there. So we both have in common that we are from a VAD and transplant center, and he will give us the perspective from his center or from his side. Thank you, Udo.
Can you hear me, Dominik?
Yes, we can.
But I can't share my slides. I'm not a moderator in this moment. perhaps.
We see your first slide.
But, okay. It's okay now?
Yeah, it's okay.
Okay. Okay. Dominik, Roberto, Mara, dear colleagues, ladies and gentlemen. Transition from VA ECMO to more advanced therapies in adults. Within the next minutes, I would like to present you our perspective, we as an LVAD and Transplant Center, with regard to this title and some general consideration, and I hope 2 interesting cases. No disclosures from my side. Now, what can be the problem with the patient on VA ECMO? It is very common that the neurologic state is often unclear. We do a CCT, often without pathologic findings. However, the patient is still neurologically unclear. He is not really awake, despite withdrawal of all sedativa, and ECMO weaning is not possible. In those patients with need for ECMO termination, we normally prefer a temporary VAD system. For example, Centrimac Levitronics, or change to a microaxial pump like described by Mara and Pella 5.0 or 5.5, if necessary, combined with a temporary AVAD like Tandem Heart. In selected patients, we nonetheless consider a durable VAD. However, heart transplantation normally never represent an option in these patients. Patient's blood group, blood type is another fact that in Germany, and I think in Eurotransplant, influences our decision for transplant or VAD. Despite high urgent listing of these patients, the waiting times, at least in Germany, remain very long. This slide depicts average waiting times of approximately 6 to 8 months for blood group 0 and 4 months in average for all other blood groups. So the blood group matters for our decision how to proceed with an ECMO patient without weaning option. Another very important fact could be demonstrated by the Vienna group around Dominik. They could clearly show that the overall outcome in patients on VA ECMO is significantly impaired when ECMO duration exceeds 7 days. So a decision how to proceed should be made within this 1 week. In the following 2 slides, focusing on ECMO patients who may be candidates for a durable VAD. As an average medical treatment, there are clearly positive and negative facts. Normally, ECMO is easy to install. It can be used for resuscitation, and it has a reliable performance. However, it is not a real VAD system. There is no possibility to drain left ventricle. In peripheral settings, we have to accept an increased afterload, and there are still no standardized weaning protocols provided in international guidelines. However, best practice for weaning and monitoring is also rather unknown and mostly center-specific. Regarding outcomes, Said and co-workers published a very interesting paper in JACC in 2020, describing results of transition from temporary to durable circulatory support systems. They describe survival rates of VA ECMO patients after implantation of durable VADs, 30 days with 77%, 1 year 53%, and only 43% after 3 years. Also, a really rare clinical situation in the Eurotransplant region. It's not the same in the United States, as you all know. Some slides describing the way directly from ECMO to heart transplantation. In blue, you can see the very small proportion of ECMO patients out of all MCS patients undergoing heart transplantation. In fact, between 2010 and 2018, only 1.2% of all adult heart transplant patients were pre-transplant supported by ECMO. As I said, it changed in the States after 2018, but it's a small proportion until this year. Pre-transplant ECMO support really represents one of the most significant risk factors for 1 year mortality after heart transplantation, as depicted in this slide. Due to the high mortality of former ECMO patients, 1 year after transplant, the survival curve remains worse compared to all other groups of former MCS and non-MCS patients. Now, let me finally come to two very interesting and comparable cases which we published already in 2017. However, two young patients with almost identical clinical course, including our complete treatment options. We reported about two young patients with cardiac decompensation, need for inotropic support, high urgent listing, subsequent resuscitation, VA ECMO, biventricular assist device, and finally successful transplantation. On the right side of this slide, some details. First, a 20-year-old woman with a dilative cardiomyopathy and late sequelae of myocarditis. Secondly, a 42-year-old man with post-myocarditis dilated cardiomyopathy. They both were listed high urgent, and immediately after high urgent listing, they had to be resuscitated, the lady for 40 and the man for 30 minutes, and we implanted a VA ECMO system, here described as ECLS. After weaning failure from ECLS, we implanted a VAD in both patients very early, 2 and 5 days after CPR and ECMO implantation. As the weaning from their ARAD support failed, we could further list the patients high urgent. We did not stop this. Patient stayed high urgent listed, and we could successfully transplant both patients 38 and 14 days, very fast. It was a wonder for us after VAD implantation, and both patients could be discharged from our department. And as you can see on this slide, one first after 4 months, and the first one already after 50 days, a successful course after this full clinical setting and these both young patients. And I think that's a story of success. It's not always this thing. Sometimes we are not successful, but that was my presentation as a center offering VAD and transplant surgery in ECMO patients. And I want to finish and to thank you for your attention.
Udo, thank you very much for this final talk. Maybe I will start with a question which often comes up in a VAD and transplant center, because as you all know, in the United States, the listing criteria were changed towards a more or a better approach for people on a short-term assist device, which have then a high urgent or UNOS 1 status for at least some time. And this resulted in a much higher number of short-term assist devices in comparison to long-term assist devices, because the people are trying to push towards transplantation directly from these devices. I'm here, at least in Vienna, always one person who is very critical to this approach, because as Udo showed kindly enough the publication, we wrote that the people only have a very short period of time till the mortality rises. So I personally don't think that this is a good approach, but what are the opinions of the panel?
Well, I think if I may start as a first speaker, I think we have, of course, the situation in the United States, I think it's a little bit different from Europe. So that is already an issue to be taken into consideration. But I want to start also from a very nice issue that either Mara and Udo pointed out. And my question is, should a patient in this condition, very, let's say, uncertain condition, be extubated or be awake as soon as possible extubated as soon as possible, if possible, and then consider for a midterm transition and support for a subsequent or let's say delayed evaluation for VAD or transplant, because you know nowadays the transplant at the urgent base is really unlikely. So, and we all know that VAD centers are not so eager, or let's say a little bit reluctant to implant VAD if they have uncertainties regarding the patient. So my question actually, because I think a lot of non-VAD and non-transplant centers are performing ECMO. So what are, or which are the characteristics and features for VAD center and VAD and transplant center to consider a patient, or should we start all the ECMO centers starting to awake the patient and put the patient on prolonged support?
I personally think that your two cases showed the difference. If you present these two cases to me, in the first case, I would not have insisted on a neurological assessment because the patient went neurologically intact into the surgery. But in the second case, I would have insisted on a neurological evaluation. And I personally think that patients like the second case would benefit from a midterm device. I don't know, maybe Mara can comment on that. Would you put the second patient of Roberto directly on an impeller or bipeller without neurological evaluation, or would you insist on having one?
Yeah, sorry. From my point of view, the neurological evaluation is mandatory for any kind of prolonged or midterm support. We can consider some exception for midterm support if we think that there are good chances for some neurological recovery. But in general, I think that this process of transition from VA ECMO to any kind of prolonged support should be an active process. So the patient should be, of course, neurologically evaluated soon, should be bridged to spontaneous breathing and so on. And the first step to achieve this active process of transition, from my point of view, is the optimization of ECMO support in some way, and for example, with more treatment of the left ventricle. And so I would like to stress the need for patient to be somehow vented for the LV unloading. And so with this kind of better support, the patient could achieve this progressive step of evaluation and maybe then transition to midterm, prolonged, and so on.
There is a question, Mara, from the audience. Does midterm VAD mean impeller? And if so, what is your timeline, days or weeks? And what's the complication rate as time passes?
Okay, so yes, what I call the mid-term support are impeller devices, but impeller from the upper body, so mainly impeller 5.0 and 5.5, so with minimal invasive approach. These systems are not percutaneous, are not transfemoral, are for upper body access, and these kind of devices are, from my point of view, a planned strategy, so are not a urgent devices, but the patient should be prepared to receive this kind of support. And about the complication, of course, they could happen. Some patients are not suitable for this kind of support. In general, the patients with aortic, mechanical aortic prosthesis, patient with some issue regarding the access the axillary artery should be at least 6 or maybe better 7 millimeters. And so there are, of course, some issues regarding the use of this machine. If there is a left ventricular thrombus, it's not possible to assist the patient with impella, and even if with mitral valve replacement, sorry, it's not so easy to use this kind of technology. But for speaking about the more common complications, I can say that thromboembolic complication such as stroke is not so common. In a recently series published in Germany about the new devices, so Impella 5.5, the rate of stroke is 2%. And the rate of pump failure, of thrombosis and hemolysis is about 15% of cases, but they have patients who were supported for a lot of time waiting next therapy. So I think that these are numbers that we can use as a initial point for this kind of technology.
Thank you very much. There is also another question actually from India for Udo. Since the prognosis of heart transplantation is better with LVAD followed by heart transplantation compared with ECMO followed by heart transplantation, do we have any clear indications to choose patients for preference of LVAD over ECMO?
Oh, that's a very good question. Consequence of my slides. I think you can't see it this way, because if you do the transfer from ECMO to VAD, you have a unique mortality and complication rate, and then the second from VAD to transplant. And if you add them, that would be more risky, I think, than the way from ECMO to transplant. But the colleague is right. It seems to be more dangerous, but you have two surgical procedures if you go via VAD, so you can't compare this in my eyes.
Maybe I hand also the next question to you, because it comes somehow in the transplant area. The question is if ECMO is doable or usable in immunodepressed patients.
After transplant, I think. Huh? What does he mean?
Yeah, I at least can say we use it post-op if a patient on transplant after transplant has a problem. So these guys are immunodepressed, but I don't think that the question really often comes to a patient who has an immunodeficiency natively goes on ECMO. I don't know.
But we don't see a problem. We are very liberal with usage of ECMO in post-operative graft failure. We had times with 30% after transplant, and former times we did not do that, but we saw that it is better than to treat them for days with high-dose inotropic medication. So we don't see a problem in immunosuppressed patients.
Yeah, and I have another question for Mara. What has your experience been in mobilizing, physically rehabilitating patients with axillary impellers in situ?
Yes, yes, I think that in this way, this kind of support is really a game changer, because it permits a complete mobilization of the patient and complete, how can I say, recovery of all the organ function apart from heart, of course. So the patient could be fully mobilized, could eat on his own, and this is a process that is not so easy to complete, and it's very useful.
And I also think, because there is another question regarding this situation, if we think that the groin-free approach of these devices is also a benefit for transplant candidates, I think we can definitely say yes to this.
Yes, we have some patients that were also bridged to heart transplant, and I think that the process is more or less the same, because the patient could receive this surgery in the best possible conditions. And from technical point of view, it is useful even for the evaluation, for example, of PVR. They could be really assessed before proceeding to heart transplantation, and some contraindications that are present at the beginning maybe disappear during the course of support with this mid-term support.
If I may just jump into the discussion, I think that we should just came to a sort of an agreement sooner or later regarding what a non-VAD and non-transplant center should do. Because at the end, I think sometimes you cannot, plan an ECMO. Most of the time you have, an out of the blue emergency, so you can't say, okay, I send this patient to a VAD center or a VAD and transplant center. So you must do it. Now, the issue is, how can I plan and make a strategy for this patient once I have the patient on ECMO? So is really, does any center have the right or have actually the duty to have also other devices which can be implanted to pass or to transition from ECMO to a midterm and then to VAD or transplant in case? Because this is, I think, the very burning question. So if I have only ECMO, am I in a much worse situation? Should I have a much tighter relationship with the VAD and transplant center to transition the patient, to transfer the patient as soon as possible? Because this is, I think, what I believe also all the centers, VAD and transplant or non-VAD and non-transplant center should know. Because I think this is a matter of organization, of planning, of resources, and so forth. So my point of view is that we must really provide a sort of vademecum, a sort of algorithm for particularly the centers not with the capacity to upgrade, to make a more advanced treatment, because this is really going to be more and more utilized. I believe that temporary mechanical circuit support will be used more and more often in the future for cardiogenic shock patients. So we must be prepared also to handle this patient. And I think at the time being, we are not very well prepared. We are putting the patient on ECMO, Impella, tandem heart, whatever, but we are not really making a precise strategy of recovery or transition. Sorry to say.
Absolutely right, Roberto. I think this is one of the major issues in this whole field, actually, and it begins with the resources topic. Because purely from a medical point of view, in an ideal world, I would say the non-VAD, non-transplant center should call me and I take the patient immediately, regardless of the situation. And once the patient is at my center, I decide in the best possible way as soon as I can. But most of the time when a non-transplant, non-VAD center calls me, I'm not able to take the patient right away. So I always have to try to bring up some selection criteria, which patient do I take when, and then the whole topic starts to get difficult, at least in my eyes.
Another question, and sorry for all of you, is because I listened to Mara, and I think this is another very critical issue. Should we try to wake up as soon as possible and extubate under support each patient? So should this be our main strategy? And then, of course, when you have the patient awake, well, that's going to be a burning issue, because what are you going to do? To switch off the machine if you are not going to VAD or transplant? So, I mean, this is very, very important also to understand for our audience. Should we go for this quick evaluation and assessment and extubate, even awakening extubation, because this is very important?
From my answer, Roberto, I think it would be great if we have one answer to these two questions. But I think that's like always in medicine, one patient is not the other patient. From my point of view, I would prefer to extubate each patient, every patient, but that's not always possible due to some comorbidities, circumstances. And the other thing is, one example, we have a very good correlation to one neighbor hospital, and they send us patients with ECMO, with ECMELA, with impeller. But they send them in always in different ways. Sometimes, as Dominik told us, one day after implantation, without trying to wean. And last week, after 7 days, with 2 weaning attempts that failed. Luckily, the patient was in a good condition coming to us, but that changes from patient to patient. And it's hard for me to tell them, please send us every patient immediately after implantation, because the cardiologists, they want to try to wean it. It's difficult. I know you don't want to hear this because you want to have a proposal for the audience, but it's very individual, I think, and I don't have the answer to these two questions.
There's also one question from the audience in this regard for all of us. From your clinical experience, do you think there are predictors for non-recoverability of a heart after acute myocardial infarction, for example, CK, troponin, etc., to early decide transition from ECMO to another device?
Mara.
Yeah, it's very interesting, this question. I do not have some limits or some range in terms of labs for deciding recovery. I think that in general, recovery of the heart, it's a very tricky issue. And I think that among recovery, there is hemodynamic recovery, there is recovery of the heart, recovery of the patient, and sometimes all of these 3 aspects comes together, or sometimes only one and not the other. So it's very difficult to go straight to recovery. I can say only one thing, that immediate recovery, it's very difficult to reach. But of course, if you have a patient with some possibility of at least hemodynamic recovery, you can understand it in the first days of support. And the second thing is that after immediate recovery, you can fight for a late recovery of the heart when you can, for example, complete revascularization of the vessel. You can use some drugs when you are still on support, and so you can explore some other strategies to obtain late recovery. So there are 2 different concepts, but I do not think that there are some range for example, CK or so on, to understand which patient could reach recovery. I don't know your opinion about, for example, transplant center, if there are more clear value for deciding on the possibility of recovery.
Well, I think that if the clinical condition and situation warns you, or let's say tells you that this is going to be the case, like the case I described, so very huge myocardial infarction, then with dissection of the left main, and so you have all the issues to, predict that the recovery, or, I always say, if you have a 60% left ventricular ejection fraction, you can still live with 20-25%. So maybe you can go to a much reduced and compromised left ventricle, but still surviving. The issue is how to get there, and I think more and more we should really take our patient by hand and make the recovery a little bit delayed. The problem is with ECMO, we encounter too many complications. That's the reason why we have to think of some better way to transition the patient from the very acute support to a mid-term support. Could be, of course, I don't know, an intra-aortic balloon pump, Impella, but we have to go and also reduce the complication of ECMO, maybe going to heparin-less support with ECMO, for instance, in the future, who knows? I mean, what I want to say is that we have been a little bit stuck to the acute support, and now we are going to face the problem of the fact that most of our patients cannot be transitioned to a more advanced therapy in the time we would like to see.
Absolutely agree. And it's really a complete different patient. If you see a chronic heart failure patient with 15% ejection fraction, he still lives. And you have an acute patient who comes with a normal function, has an infarction and goes to 25%, but he doesn't live. So there is an enormous difference between an acute and a chronic phase. There's again a question from the audience for Mara, I think especially, but maybe also for Udo, about the complications of Impella 5.5 from axillary artery. Are there any specific complications you realized?
Not any specific, as I mentioned before. No, not any specific complications. In the first version of Impella 5.5, there were some issue about the dislocation of the inflow, the outflow, because the device was too short. But this new version that is longer, it's very easy to position, and then it stays there.
And one statement, I think it's important. If we are not able to define a time point for stepping up, for going to a VAD or a VAD transplant center, we should pronounce that it is important, as Roberto did it, that the contact is immediately. That you, as a center not offering VAD or transplant, that you contact your center within the first days, at least to plan what you do, that they know that there's a patient, and then you are in contact and you can react faster than if you make the first telephone call 8 or 9 days after implantation and 3 weaning failures. That is a very important thing, I think.
Maybe I'm going to close with a provocative statement, but I have also to say that this kind of relation you mentioned, Udo, must be very nice. And why? Because maybe I can even not agree with the transplant VAD and transplant center going to do. And that was a patient for whom we worked. Everybody works, but maybe the strategy is not agreed, is not, how to say, shared. So my point of view is that we have to really work more in the future, close each one, and make really the hub and spoke network much better than it is now. Because we can also decide that, okay, if you are not going to put a VAD or transplant, that we, as a non-VAD and non-transplant center, are going to make something else. So, but this will be discussed and agreed among every partner of this network. And this is why I think this webinar was really nice and timely, because we really need to change a little bit our attitude towards this problem. I think it was very much given for granted in the past. Okay, no recovery, untransplant or VAD. Well, that's not the case. Most of the time, this happens very rarely. And so we have to really make, as Mara said, a sort of a game changer or game changing in our strategy, and make a little bit more, we should reflect a little more about what we are going to do in alternative, I think.
Yeah, Roberto, I completely agree with you. And from a LVAD implanting center, but not the transplant center, for us, it was very important to have such kind as a a structured and constant relationship, for example, with an heart transplant center. Because, you know, I think that every step of this kind of advanced treatment should be, of course, shared. Because if you shared, you will find the right way for that patient. Otherwise, you will find and you will be always frustrated because you can't see where you are going, or you are waiting and sitting, but you can obtain what you want. So I think that this kind of relationship that is structured and came before the consultation of this specific case, it's built before.
Yeah, absolutely, because, you know, I can decide that if I am in a peripheral ECMO or the femoral artery, and the heart transplant center saying, okay, we wait another week, okay, so that I can change to the axillary artery and go to a different configuration in the meantime, or stopping heparin because I am feared or I'm concerned about hemorrhagic stroke. No, I mean, we have to make really new recommendation and new, show new strategies and new way of also handling this problem, because I think that for the time being we do not have that recommendation, I think, unfortunately.
Absolutely. I think with these words we can conclude the webinar. There are still some questions. However, I think we are already a little bit running out of time. From my personal perspective, it is very important to build these inter-hospital networks, and I completely agree with Roberto that we should work on recommendations in this regard, because we don't have them simply. And this is, I think, a conclusion for all three perspectives which we have in common, that there is a need to connect us better together.
Okay. So thank you very much.
Thank you.